Good morning, everyone. Thank you for coming to our workshop today. I'm Ann Yachtine. I'm the director of the Food Nutrition Board and very pleased to have been a part of this effort. I think it's really been, it's unusual for the Food Nutrition Board to take on this type of a project, but it's really been an excellent experience. And I really thank the Planning Committee for their efforts in pulling this together. And I want to begin by introducing our first moderator, who is going to be Dr. Cheryl Rock. And Dr. Rock is also the chair of the Planning Committee. She is professor in the Department of Family Medicine and Public Health and the Cancer Prevention and Control Program at the University of California, San Diego. Dr. Rock's research focuses on the role of nutritional and dietary factors in the development and progression of cancer, particularly breast cancer, and healthy weight management in adults. Dr. Rock, thank you for coming.
Thank you, Ann. So I welcome you also to this exciting workshop. I know you're all looking forward to an interesting day that will be very informative, and we'll have a lot of good discussion as well. So first, I'd like to introduce our keynote speaker, Stephen Clinton, MD, PhD. He's a professor in the Department of Internal Medicine, the Division of Medical Oncology at The Ohio State University. Dr. Clinton is also the program leader for the Molecular Carcinogenesis and Chemoprevention Program of the Comprehensive Cancer Center at The Ohio State. He serves also as the James Cancer at the James Cancer Hospital as the Director of Prostate and Genitourinary Oncology. His cancer research interests within nutritional sciences include the roles of energy intake, bioactive lipids, vitamin D, carotenoids, and other phytochemicals. So we are truly thrilled to have Dr. Clinton as our keynote speaker, and I'll turn it over to him.
All right, well, many thanks to Cheryl and all of you who are here today, and particularly those who are with us on the internet. It was a long time coming to have a session that's pulling together different interests relating to the access to nutrition care in outpatient cancer centers. And I'd like to just set the stage today, give you a very brief overview that will kind of get us warmed up for the presentations that are coming later on this morning and this afternoon. Now, the so-called war on cancer began back when I was, I should say, just starting undergraduate school, and it began with Richard Nixon signing the Cancer Act in 1971. And this achieved many wonderful outcomes over the years. We've seen the development of over 40 some comprehensive cancer centers. We have seen the establishment of cooperative groups for the conduct of phase 3 randomized trials that more efficiently bring new ideas in translation of basic science into clinical care for the benefit of millions of folks with cancer. The comprehensive cancer centers also provide a framework for training in expert care that can be brought out into community settings. And we've seen some progress, although those of us working in the field may never feel it's enough. But we see that the cancer incidence rates after decades of increases have plateaued and are beginning to maybe decline. We also see very significant changes in cancer mortality for both men and women. We've peaked. We're clearly on a decline. And these are things that we should be really proud of based upon the efforts of so many people and the investment of our taxpayers through the National Institutes of Health and other funding agencies. But these trends are giving us some new challenges. The number of cancer survivors is increasing quite dramatically from 4 million in 1975, 14 million today, and potentially 24 million by 2024. If we couple this data with the aging population in the United States, which I don't view as a problem anymore, just simply a minor challenge, a stable incidence coupled with improved survival rates and an aging population means that the actual burden of cancer is increasing. We have 1.6 million new cases in 2016 alone. We couple this challenge with the rising cost of cancer care. Cancer care is the one area of medicine that is expanding at a rate that exceeds virtually every other. And I'm astounded at the costs of the drugs that we use to treat patients in my clinic. $124 billion are expended in 2010, expected to rise to $158 billion in 2020. This is an enormous cost to our healthcare system, and indeed to all of us. So, where are we in the war on cancer with regards to the role of diet, nutrition, and physical activity? So, over these decades, we have seen a tremendous expansion of scientific evidence. Think of what epidemiology was like back when I started graduate school. We were just beginning to see the first studies of the application of food frequency questionnaires and the development of cohort studies, the wonderful molecular biology era and mechanisms of action of different nutrients in cancer. One of the great things over recent decades was the development of systematic reviews, and I think the AICR, WCRF, and other organizations that have taken it upon themselves to organize our data on diet, nutrition, and cancer in a way that becomes a useful tool, not only for researchers, but for governments that are interested in public policy in the United States as well as around the world. So we have wonderful public health recommendations. However, this knowledge base and growth in scientific evidence has left us with an enormous potential to reduce the cancer burden, but yet perhaps we're not satisfied with the next step in that process. I think we have achieved enough information in many realms where diet, nutrition, physical activity could significantly and dramatically reduce cancer incidence. We know that there is wonderful data emerging showing how we can enhance therapeutic efficacy, that we can reduce toxicity and complications of therapy, promote healthy survivorship. After all, if someone has fought the battle with cancer and is looking forward to a life expectancy similar to others, we really find that this teachable moment is one we should take advantage of to promote healthy survivorship, quality of life, not just to reduce the risk of recurrence, second cancers, but also to improve their health with regards to other chronic disease outcomes. And finally, the integration of diet and nutrition, both in prevention as well as our clinical care, could enormously impact healthcare expenditures for cancer. So these are our goals, and I'm hoping today with the work that you will see presented, the stimulation that you have, we will all be working on this next step in our challenge, which is defined here as implementation. So as much as I grew up out of the realm of the scientific endeavor and the research, the frustration that I have now not only is in the funding for nutrition and cancer research, but perhaps more so in the fact that we are not implementing and putting to use or translating the knowledge that we have accumulated and the information that we have at our fingertips. So, as we leave today, we want to remember that this is the first step in the process of putting decision or plan into effect. We need to execute the plan. So I thought I would highlight a few of the barriers that I see in this process before we get into some of the details later today. And I'll initially just pay homage to the public health prevention strategy, which is not the main objective here today, but I think we need to recognize that the enormous amount of research that has gone on with regards to diet, nutrition, exercise, and cancer risk etiology have been beautifully reviewed and organized by the AICR-WCRF, who, if you don't know, have recently become more closely affiliated with the World Health Organization in providing these guidelines globally, and in other committees such as Dietary Guidelines for America. The big challenge to implementing these efforts, I just put in quotes here and call it political. There are many steps in this layered process to bring these things into effect, and that's worthy of another meeting in and of itself. But what we're focusing on primarily today is the medical model, meaning taking care of individuals. And our American health care, in quotation, system, more and more when I'm talking with my patients, I call it the American health finance system. And this always begins with a discussion of education and manpower with regards to diet, nutrition, and cancer in the clinics. And often, many people will say to me, we really need to spend more time training our physicians in nutrition. And I put in parentheses that that same commentary could relate to nursing, nurse practitioners, physician's assistants, et cetera, et cetera. But in recent years, I've actually taken a little bit of a different view on this. And we had a wonderful discussion at a meeting a week or so ago regarding dietary guidelines, where someone very eloquently discussed at their institution how they are increasing the number of lectures for medical students. They are doing wonderful hands-on cooking demonstrations with chefs, et cetera, et cetera. I wish I had that. That would have been a lot of fun. And I suspect the main outcome of that in your first year of medical school is socialization with your peers and perhaps eating a little bit better at home. When you think of what it takes to train a physician, medical school, 4 years, in my case, 3 years of internal medicine, internship and residency, 3 more years of medical oncology. Do you really think those 2 or 3 lectures your first year of medical school mean anything? Absolutely not. So what we need to do is bring a little more of this awareness of nutrition into training in the subsequent clinical steps. I think in medical school you should just eliminate the word biochemistry and change that course from to nutrition and metabolism, which is really what it is. But I really think the most important thing to teach or educate physicians is going to be how to use the talent pool that is there at your right hand. And that will continue to be the RDs or RDNs. I mean, it amazes me that we think that the physician needs to be the nutritionist when, if I'm taking care of a patient with cancer and I need radiation therapy for them, I don't do it. I get the radiation therapist to do it. If I need physical therapy for the patient, I get the physical therapist to do it. If I have questions about the drugs, I work with the pharmacist. So why are we thinking that the physician should be providing the nutrition education to the patient? They're not trained. They need to be doing their job. And their job is to provide the medical care and use the tools that are there to help you get the best outcome. So I think that if we are successful in the years to come, we're going to need more training. We're going to need more folks trained to be dietitians and nutritionists. And I would propose that we need more grants at institutions that have the infrastructure that are combined degree training programs. So RD, PhDs particularly, that are going to be at the forefront of teaching, education, and also being involved in clinical care, where they can really bring that level of expertise to the bedside. The next barrier is perhaps the most important. Reimbursement for RD, RDN care. If we don't see better reimbursement for these services, it will never happen. I mean, this is simply the way our health finance system is working. A hospital, an institution will not invest in this service unless it is reimbursed through the insurance, through Medicare, Medicaid, etc. The financial challenges, though, are really deep. We are seeing a shifting of costs of health care to the patient. In spite of our healthcare system that we might label as Obamacare, which did bring insurance to millions of people, we still have found a way to shift more of the healthcare costs to the patient. Insurance costs are rising. There's an erosion of employer-based coverage. And every January 1, my clinic suffers enormously from the higher copayments that everybody needs to pay. Increasing annual deductibles. I have seen in the first month in January, a patient who in December paid $15 copays for his pain medications. This is someone who will not survive their cancer. After January 1, that copay is $400. And this is for pain medicines, folks. Now, how are we going to achieve payment for nutritional services if copays and that kind of a structure are going to continue to exist? And then I think we also have this continued loss of our middle class and social and economic disparities that continue to grow and make it a challenge to provide these copayments, insurance, and deductibles. So the financial side of this is an enormous obstacle, and I think we need to be organized in how we're going to move forward in this realm. There will be a need for infrastructure. I know when I call a dietitian who may be free because, after all, she's covering 5 different buildings and 4,000 patients in one day, when they can come to our clinic to see a patient, where is the space? A busy clinician is moving through their clinic, using every room every so many minutes, and we're lucky if they can talk to them in the waiting room. There needs to be dedicated space and infrastructure, and we need to find ways to use our tools and integrate them within the electronic medical records to be sure that the work we're doing, the data we're collecting, is readily available to everyone on the healthcare team and readily communicated. We need standards of care. So I know organizations have worked on this in various ways. We have to utilize our various organizations, perhaps get them to work together to complete systematic reviews of the data, come up with standards of care, and have those peer-reviewed very carefully. And one of the good examples, and I'll focus on the NCCN guidelines, the National Cooperative Cancer Network, that does provide guidelines for cancer therapy. If you look through these dozens of very, very elegantly done guidelines for cancer therapy, you will see a few that include nutrition, but very few. And I think for all of us that work in cancer, you can pick out certain diseases where the nutrition part is better established. And let's give an example: head and neck or oral cancer. where these enormous surgical procedures coupled with chemotherapy and radiation make it so difficult for a patient to consume the amount of food, the right types of food that will promote their care. There we have very, very clear and strong evidence of how diet and nutritional support with the help of dietitians and support teams greatly improve the outcomes of disease. And I think we need this for all of the disease. I don't think there should be an NCCN guideline that doesn't pay some homage to nutrition in the future. But I think we need to define these standards and make them readily available to our practitioners around the country. And I've added another one point here, and that is the supplement industry and what I'll label as nutritional quackery. And again, the challenge here is political. I don't know what all of you may think of DSHEA. I think, we either revise or repeal and start over again. We need to enhance FDA oversight, and the Office of Dietary Supplements, which is phenomenal, needs to be empowered to do more, to provide the education that we need for our cancer patients. And I think we all appreciate that so many of our patients, when they complete their moment of active care, whether they've been in adjuvant chemotherapy or recovering from surgery and radiation, there is a point in time where the clinician says, well, congratulations, we'll see you in 3 months. And all of a sudden, that intense care, that interaction with all the caregivers is somewhat severed. This is this moment when so many people make the transition to, wow, they're stepping back. I need to step up and do something for myself. And so your high school student who is working down at the local health food store becomes the provider of advice and guidance for cancer survivorship, or there's much worse than that, let's say. It's kind of like the Wizard of Oz, so to speak. So I think the supplement industry and nutritional quackery is one of the biggest challenges that we have for our cancer survivors. So I'll end my introduction today and leave you with some great presentations and discussions that are going to come as the day proceeds. I think it's time for all of us to take greater action in this arena. All of our professional organizations need to be made aware of the potential that we have in this discipline to carry this mission forward in the war on cancer. And there's no doubt that we can have a very dramatic and significant impact. So learn today, speak up, and act. Thank you very much.
Thank you very much, Dr. Clinton. You really set the stage for what we hope to engage and address today throughout the rest of our presentations. So at this point, I'd like to spend our next 35 minutes talking about the 6 sponsors who contributed more than $10,000 in support of this workshop. And if you could all come up and join us here at the panel as I present your name, I'll introduce all of you, and then we'll go down the table, and each of you will have 5 minutes that you can describe your interest and area of focus. Deirdre McGinley-Gieser for the American Institute for Cancer Research. We also have Elaine Trujillo from the Nutrition Science Research Group at the National Cancer Institute. Russell Clayton from Alcresta Incorporated. Colleen Doyle from the American Cancer Society. Katrina Claghorn for the Oncology Nutrition and the Clinical Nutrition Management Dietetic Practice Groups. And last but not least, Alison Steiber for the Academy of Nutrition and Dietetics and the A&D Foundation. And we welcome you all, and we'll start with, we'll start with Deirdre. In 5 minutes, if you could describe the AICR focus and your interest and sponsorship of this workshop.
Pushing the wrong button. Thank you. Good morning. I'm so pleased to be here today representing AICR at this really important workshop. And I'll keep my remarks very short, probably less than 5 minutes, because I know we have a very full day of discussion that really is the purpose that we need to get to. So for those of you who do not know AICR, we're the American Institute for Cancer Research. We're a national nonprofit based here in Washington, D.C. And we focus on the link between nutrition, physical activity, weight management, and the risk of cancer. So today's agenda really goes to the heart of our mission. AICR's evidence has shown for many years now that diet and nutrition plays a crucial role not only in prevention, but in treatment and survivorship. Patients and families recognize the importance of diet, and they're receptive to making healthy changes. They're asking for help, but they still do not have the access to the experts, the oncology dietitians. Oncology dietitians can help patients manage the side effects and other difficulties during treatment and get them onto the path to lifelong healthy eating habits after treatment. And evidence-based nutrition information from diagnosis on can make the difference that leads to successful treatment and recovery. AICR had a preview of the issues surrounding access to nutrition care in cancer centers at our last research conference. The program chair for that conference happened to be Dr. Rock, and she urged us to schedule a breakfast session around this topic. We took her advice, and Elaine, Roan, and Suzanne planned a very well-attended session, despite the early hour, that generated lots of helpful discussion and ideas for next steps. So in closing, I'd like to particularly thank the Oncology DPG and the Institute of Medicine for championing this topic and making this workshop a reality. AICR really wants to see improved access to nutrition services. It's part of who we are and what we do, and we're very proud to help support the work to get us there today, but also going into the future. So we see our role here as continuing to support the workshop and the work that comes out of it today. Thank you.
Thank you, Deirdre. So next on our panel is Elaine Trujillo from the National Cancer Institute.
Yes, good morning. It's a pleasure to be here, and as Steve said, it's a long time coming. I'm really, actually, more than happy. I'm ecstatic to be here and see this day happening. And I'm happy to be representing the National Institutes of Health, and at the NIH, we believe, as all of you do, that we believe that nutrition services are needed in cancer centers. There are 69 NCI-designated cancer centers where over 250,000 people receive diagnosis and treatment. And as you know, here in the United States, we provide some of the best quality care of cancer patients in the world. And because of that, many people from around the world come to the United States seeking out our treatment. And so then I have to ask the question, how is it possible with this wonderful treatment that nutrition, which is so basic, so fundamental, so essential for life, how is it that a patient can go from diagnosis to survivorship and not receive routine nutrition care? How is it possible that there's one dietitian for every 2,600 patients in NCI-designated cancer centers? So I think that's really why we're here today, and I think this is the opportunity to start talking about the next steps so that every cancer facility where they offer treatment is equipped with nutritional services. Evidence indicates that scientific data continues to be inadequately applied to the clinical practice. And certainly that's the case for nutrition and advances in nutritional science. Without access to nutritional services, is this research trickling down to the patients? Historically, we thought about nutrition status of cancer patients in terms of cachexia and anorexia, and I think these days we also think about obesity. And obesity is a growing problem in the cancer population, both patients and survivors. And we know there is good evidence showing that cancer survivors do respond well to weight loss treatments, but there's very few weight loss treatment opportunities available for cancer patients and survivors. And in fact, the American Cancer ACE American Society of Clinical Oncology came out with a report, I believe in 2014, really emphasizing the oncology community's commitment to strategize and look for ways to implement nutrition weight loss programs for cancer survivors. So those types of strategies, I believe, are needed. Sarcopenia in cancer patients is associated with poor functional status, shorter survival, and higher incidence of dose-limiting toxicity. And a particular group at risk are those with sarcopenic obesity, and they are oftentimes missed as being at high nutritional risk. They're just often ignored, and so implementation of standards would help in identifying these patients and other patients who are at nutritional risk. Data is needed to make the case for reimbursement for nutritional services. The scientific community needs to talk with folks from CMS and address healthcare reimbursement, Medicaid reimbursement, especially since so many survivors are 65 years and older. Billing and reimbursement, I mean, we can't kid ourselves, it's very, very complicated, but we need to look at data, we need to investigate more billing behaviors and how to tackle that. NCI is interested in increasing quality of care while balancing the costs. Poor nutritional status has been associated with increased hospital costs, but there's very few studies who look at the cost effectiveness of nutritional interventions. So we need to think about what type of data is best to capture the cost savings. The Office of Dietary Supplements is interested in understanding the current use of dietary supplements in cancer patients, which is a lot higher than the use of dietary supplements in the general American population. And so although some supplements may be beneficial, others may cause serious side effects and interfere with cancer treatment. As you know, supplement use is often underreported. The Division of Cancer Prevention at the NCI has sponsored large clinical trials using dietary supplements and have found them to be harmful. So given the extensive array of dietary supplement use in cancer patients, RDs who are often asking patients their use of dietary supplements, they really need to be at the table and be talking to patients about the safety and efficacy of supplement use and be part of the multidisciplinary care team. I want to thank the Planning Committee for their time and efforts in this initiative. I want to thank Ann Yakin, who really is our champion for oncology nutrition. Thank you, Ann. And I do want to say that I really feel that nutrition and nutrition experts have sort of not always been at the table, so to speak. And I think initiatives like this and bringing all these people together can position us so that we are at the table and part of the team. Thank you.
Thank you. So I'd now invite Russell Clayton from Alcresta to present his opinion and agenda for this.
Thank you very much. My name is Russell Clayton. I'm the Chief Medical Officer for Alcresta Pharmaceuticals. And given the recent political commercials, I feel the need to say I approve this message. First, I'd like to thank the organizers of this conference for putting together a very interesting agenda and for allowing people like me to have a few minutes to speak. In November of last year, the FDA cleared our product, Relizorb, for use in adults to hydrolyze fats in enteral formula. The device, Relizorb, is designed to use with enteral nutrition, or tube feeding as it's sometimes referred to, for a particular subset of patients, and this is a subset of patients who cannot hydrolyze fats. They have, for example, pancreatic insufficiency, and so logically, we looked at a potential patient population of patients with pancreatic cancer. And so as I started speaking with dietitians and oncologists with regard to the potential use for the product, some folks were very enthusiastic about learning about the product, but others were not. And I was puzzled by that because the answer I got is, well, we don't use enteral nutrition in those patients. And I was puzzled, so I asked questions as to why, because 65 to 85% of patients with pancreatic cancer have malnutrition, and clearly guidelines such as the Aspen guidelines spell out that if you meet certain criteria, you should receive some form of nutrition, and enteral nutrition is preferred to parenteral nutrition. The answers I got staggered me a little bit. One answer was that enteral nutrition is not reimbursed by healthcare insurers. And I know that my wife works for the largest health insurer in the country. I asked her about that. I said, well, it is, but you have to meet certain criteria, which oddly enough doesn't necessarily meet some of the criteria of the major organizations that know best, I believe, about nutrition and when to put enteral nutrition in place. So aside from reimbursement, the next answer was, well, we don't really have the resources, in other words, the staff to help manage those patients on enteral nutrition, and that also bothered me, and that's been discussed already, so I won't dwell on that. But I guess the most troubling answer I got was, a lot of patients with pancreatic cancer are incurable. They have a relatively short future, let's say, a dim prognosis. And placing a feeding tube confuses the end-of-life issues that come up. And I was really bothered by that. My father passed away from complications due to lymphoma, and the treatments and the disease were bad enough, but I can't imagine spending his last days watching malnutrition contribute to those last days. So whether we're fighting for survivorship or whether we're fighting just to make our last days as dignified and comfortable as possible, malnutrition should not be part of the problem here. So I came here today to learn and to speak to folks who are really interested in this, to try to help understand what Alcresta can do to remove some of those barriers so the patients who require enteral nutrition can get it without having these issues to deal with. So again, thanks to the organizers, and I look forward to a great day. Thanks for your attention.
Thank you. So our next panel sponsor to present their interest in this activity is Colleen Doyle, who represents the American Cancer Society.
Good morning. Very nice to be here. And Elaine, I have to say, I can't remember what city it was, but a few years ago at the Academy meeting, we were at a practice group meeting and talking about the concept of this meeting coming together. And it's just really exciting that here we are. So thank you. And we are really, really thrilled to be part of it. I'm not going to say much because you're going to hear from me later, but the idea of supporting cancer patients and survivors in nutrition, physical activity is so critical to the American Cancer Society and our mission. Certainly our goal is to help save more lives from cancer. And we know that both from a survivorship perspective and a prevention perspective, how critically important nutrition and physical activity both are through that cancer continuum. And we are thrilled to be part of this meeting. We are thrilled to work with our partners across the table here, and I see a number out in the audience as well. Really excited to help move this issue, to help expand nutrition services for cancer patients, to help create healthy environments for those patients to live in, where barriers to eating well and being active are reduced. We are excited from an advocacy perspective. Steve, you brought up the reimbursement issue. That's a critically important issue. And I think that's one thing, and I see one of my ACSKN colleagues in the room right now. One thing I think that the American Cancer Society has a real opportunity to bring to this table is the strength of our advocacy efforts. This is an issue that we actually held a policy roundtable meeting early December on to talk about what are the types of issues from a survivorship perspective that need to be addressed from a policy perspective. And so really looking forward to help advance those issues as well. But thank you very much for being here. I look forward to participating and meeting many of you hopefully throughout the day. Thanks.
Thank you, Colleen. So next we have Alison Steiber from the Academy of Nutrition and Dietetics. I almost said the American Dietetic Association.
It's okay,
I apologize. And the Academy of Nutrition and Dietetics Foundation.
Great. So good morning, and thank you everyone for who's responsible for organizing this meeting. It's really exciting to see nutrition at the IOM in such a prevalent way and such a impressive array of speakers and an important topic. The Academy of Nutrition and Dietetics was founded in 1917 in Cleveland, Ohio, and 100 years later we have over 100,000 credentialed practitioners. Not enough, as was very clearly and eloquently pointed out by Dr. Clinton, but certainly we have a large workforce. And that workforce comes to the Academy for many different things. Everything from advocacy, which is done a lot by our DC team in Mary Pat Ramonde and Jeannie Blankenship, and also through the professional resources, through education, and through research. And so I am responsible for the research arm of what we do here at the Academy. And one of the biggest member benefits that we have is the evidence analysis library. And I love that Dr. Clinton pointed out the systematic reviews. The evidence analysis library really is focused on creating systematic reviews that are evidence-based, and they pull together nutrition information that is human, based in human literature. Those systematic reviews then, as appropriate, go on to develop evidence-based practice guidelines. And it's those guidelines that really help practitioners make sure what they're doing has the evidence and the science behind them. In 2013, we released the Oncology Evidence-Based Practice Guideline, which was a huge undertaking, and many of you in this room may have seen it or have been a part of the creation. From that, we have 5 nutrition screening recommendations, 6 nutrition assessment recommendations, 1 nutrition diagnosis recommendation, 8 nutrition intervention recommendations, 2 for monitoring and evaluation, and 1 for outcomes management. It is a huge project, and I encourage you to take a look at it if you haven't seen it. One of the systematic reviews that came from that showed nutrition status and outcomes. And from that, we had 5 grade 1 statements, conclusion statements, that showed the importance of nutrition status and hospital length of stay, quality of life, chemotherapy and radiation tolerance, treatment tolerance, and mortality. Just really emphasizing the importance of nutrition in our patient population. But creating these evidence-based practice guidelines alone is not enough. We also need to take that information and then collect outcomes as practitioners. And I love this IOM workshop because you're so focused on outcomes. One of the things that we have done in the last couple years is create a program, or a web-based program, that allows clinicians to collect outcomes, and it's called the Academy of Nutrition and Dietetics Health Informatics Infrastructure, and because that's a huge mouthful, we just say ANDI. The ANDI program allows us to have a dietetics outcome registry that currently has over 550 visits worth of data in that outcome registry, and we just submitted our first abstract to FNCE. With this tool, we can take those guidelines that were given to us by this great work group, and we can begin to collect outcomes. Did the guidelines work? Did we improve outcomes when we implemented the interventions that were promoted by the guideline? It's these kind of efforts that not only synthesizing the data, but also generating new data so that we can fine-tune and improve our guidelines will really help shape outcomes and quality of life for our patient population. So I thank you for allowing me to be part of this panel and for all the work that you're doing today. Before and after, I assume there will be a lot of work to be done to carry out your recommendations. So thank you.
So next, I'd like to turn this over to Katrina Claghorn, who represents the Oncology Nutrition and the Clinical Nutrition Management Dietetic Practice Groups.
Thank you. I am an outpatient oncology dietitian, so I work in the trenches, and it is such an honor to represent the Oncology Nutrition Dietetic Practice Group today. This is such an historic day for oncology dietitians and for all registered dietitians. ONDPG has once again accomplished a major milestone. However, we could not have arrived at this day without the support of so many who understand the significance of this initiative and the importance of establishing standards of care in outpatient oncology nutrition. Outpatient oncology nutrition has truly evolved into its own field of practice over the past 20 years, especially with the shift to outpatient care. It is amazing to realize that 90% of cancer care is now provided in the outpatient clinic. I have been in the field for 20 years and have personally experienced this shift. I've seen the growth in the number of outpatient cancer centers, but have been troubled by not seeing a corresponding increase in dietitians in these facilities. Over the years, I have frequently received calls from dietitians new to outpatient oncology, seeking advice on guidelines for care, how to screen and triage patients, questions about staffing ratios, and I find it frustrating that I cannot provide concrete answers. The program today will help validate the integral role nutrition therapy plays in cancer care, which dietitians in the clinical trenches witness daily. There is perhaps no other area of medicine where the risk of malnutrition is greater. I often refer to a table from Nutrition and Clinical Practice listing the diseases and conditions most associated with malnutrition to address this point. The diseases in order of malnutrition risk are pancreatic cancer, lung cancer, head and neck cancer, and gastrointestinal cancer, followed by stroke and COPD. That's right, the top 4 diseases are cancers. Many of us have witnessed how medical nutrition therapy delivered by dietitians can help prevent delays in treatment, prevent unplanned hospitalizations, avoid reactionary nutrition support, while improving outcomes and patient satisfaction and reducing the cost of care. Registered dietitians also serve an important role helping cancer survivors with the long-term side effects related to treatment, one of the most challenging being obesity, which has been associated with cancer progression. And let us not forget our role as the member who acts as the intermediary between conventional medicine and complementary medicine practitioners. How often have you received a STAT consult to review a list of supplements? But to move our field forward, we need practice guidelines and standards of care, which is why today is such a pivotal moment in oncology nutrition. This conference couldn't be more timely or essential in galvanizing action and providing future direction to ensure that dietitians will have a seat at the table. ONDPG thanks the sponsors, sponsoring companies and institutions, as well as the groups and individuals who recognize the impact of dietitians and MMT in cancer patients' outcomes by supporting this initiative. A special thanks to the Clinical Nutrition Managers Dietetic Practice Group, who saw the broader impact of the workshop on the dietetic profession. As Carolyn Steele, the chair, noted, our common concern is improving patient access to nutrition care, improving the quality and timing of nutrition intervention, and the improvement of access to nutritional services for all cancer patients. The results of this workshop will have implications for the delivery of outpatient nutrition services across all disease sites. Also, I want to recognize the dedication of my fellow committee members who all worked so hard for this day: Roan Levine, Suzanne Dixon, and Janine Meals. And an enormous thanks to the 2 individuals who championed the workshop relentlessly with such passion over the past 3, now going on 4 years. The Institute of Medicine's Ann Yachtin and our own indomitable Elaine Trujillo. And finally, to all the members of ONDPG, thank you for your unwavering and generous support.
Thank you, Katrina. Since we're running a little bit ahead of our schedule, I'd like to move something up from the agenda, and that is to recognize the additional sponsors. So as I read your name, if you'd stand up and we can thank you personally for your sponsorship. First, Noreen Liss, sorry I butchered your name, from Option Care Incorporated. Thank you. And then Susan Ratton from Savor Health. Or Susan? Thank you. Thank you. We appreciate your support. And Ann Fonfa of the Annie Appleseed Project. Thank you, Ann. So excellent. So now the panelists can join the audience, and we're going to move ahead and start our first session. We'll give you a moment to get organized. Thank you.